Yes.
All right. Thank you so much. Well, hello to everyone from home. And hello to everyone here in the room with me. My name is Dr. Josh Bradstatter. I'm an oncologist here at the University of Pennsylvania, or I guess there at the University of Pennsylvania. I did my training entirely here at Penn, both internal medicine and hematology oncology before, and I did an MD PhD at Duke University, where I studied immunology. I even did a master's before that in Oxford, where I was studying immunology. So I loved the immune system and how it works for a very long time. I got recruited to David's cause from my personal experiences here, taking care of Castleman disease patients as a resident. And then also in terms of the development of my research interests, in terms of understanding how the immune system goes wrong and causes human disease. So that's kind of what brought me here. Right now, I'm wearing a few different hats. I'm mostly in the lab, pipetting, whispering to mice, trying to answer some of these big questions that we kind of have to hunt in clinic, which is, what caused this disease? Why was it such a painful experience getting diagnosed? And why did all these different doctors disagree about my diagnosis? And what other, why is there not more treatments available? So those are the questions I try to answer in the lab. And otherwise, I see patients about half a day every other week, Castleman disease patients, other rare diseases called histiocytic disorders, which are rare blood disorders, and then lymphoma, general lymphoma as well, which is a cancer of the white blood cells. The other hat that I wear is as part of the team here at the CSTL, where I am the director for clinical science and coordinating our clinical research. So that Accelerate Natural History Registry, I am newly in charge of shepherding both its construction, maintenance, making sure that we can help get everyone's records into the system, put it in there in an organized fashion. This person right here is Aurora, plays a very, very big part of that. And then help kind of crowdsource for what sort of questions we want to ask this huge database of everyone's different experience, real world experiences with Castleman, and then turn that into new insights into the disease. And excitingly, this was yesterday now, we just got a paper published in the American Journal of Hematology trying to talk about different patients' experiences with unicentric Castleman disease, their real world experiences, both as felt, as we can get from the Accelerate registry, and then also maybe a survey that maybe some people in this room participated in, or people online participated in, that helps inform the wider clinician, group of clinicians who may be seeing Castleman patients, that in fact, unicentric disease isn't always just a matter of you get your surgery and you're done forever, that it's more complicated than that. And so this way, that there's information out there accessible to another doctor on the other end of the continent or world that would be able to know that it's not just this one patient that they've seen that's experiencing this problems of symptoms after surgery, but a lot of other people, and sharing those experiences. That's the whole point of generating this clinical database, and that's why I'm plugging it right now if you're not participating in, to join it, because it helps us to conglomerate everyone's experiences together in one place, and then use that idea that we can have this privileged position to have access to a lot of different people's experiences and find themes that we can then share with the wider audience of physicians, so that hopefully the idea is that later patients don't have to have the same frustrating experience that I presume almost everyone in this room had in terms of their diagnosis and maybe even continue to experience current management. So that's who I am. That's a plug for Accelerate, since I'm taking over that role from a very beloved member of the team previously, Sheila Pearson. And that's how I got involved with the Castleman disease program here at the University of Pennsylvania. I put this slide here about unicentric Castleman disease being rare and poorly understood in order to preface everything I'm saying with a bit of humility. I think we're doing a great job starting to learn more and more about Castleman. Certainly, we're doing a lot. We're uniting a lot of different people together around the world in trying to study this in a more systemic way and sharing experiences. But it's still a rare disease, and there's still a lot that's unknown. So I apologize up front if I'm going to say things about the disease that don't fit your particular lived experience with the disease. And I'm saying that with the important caveats that we still don't know everything, and a lot of people's experiences have been individualized or different. But these are some of the general thoughts on what we have in unicentric Castleman disease. It is by definition a single region of enlarged lymph nodes. It looks like Castleman under the microscope. We have this nice science section here to help suss out exactly what that means. And then it's clearly not anything else, which is one of the tip-offs that you know that we're having some struggle with defining and the diagnosis of the disease, and that we have to say, if it's actually something else, then it can't be Castleman, and that's baked into the diagnosis. It's often, for most people, asymptomatic. It can be accidentally discovered. See a lot of patients who had some sort of like trauma or car accident or something like that. They get an image, and lo and behold, there's a lymph node that they had otherwise no way of knowing about. But that's certainly not always the case. And I presume for most of the people who are participating in this, that's definitely not the case. It's a rare disease overall, and it generally has an excellent prognosis with a very good survival, long-term survival. So, as I said, we are learning more. This was a paper that came out, I want to say 2 years ago now, where we published. This is our group. Well, you'll see a lot of familiar names. People will be talking today. A unified consensus diagnostic and treatment guidelines for unicentric Castleman disease. And when I wrote this, I said more to come. I was when the paper was still in review at AJH, and now it's accepted. So it's come very soon. So our knowledge is advancing. We're making progress with our understanding of the disease. Oh, I'm sorry. Oh, there's someone in the chat, you're saying? Oh, okay. I see what you're saying. There we go. All right. In addition to unicentric disease and multicentric disease, we have an increasing appreciation that there's a disease in between. So uni-1, multi-many, and there's also oligocentric Castleman disease, few, where maybe there's technically more than one involved lymph node stations, but the patients tend to present very similarly overall to unicentric disease. Oftentimes, they don't have any systemic symptoms, or perhaps they do, but they're a little bit like multicentric, but maybe they don't quite meet all the criteria for being multicentric disease. So they probably will have 2 or 3 different involved lymph node areas. They're usually adjacent to each other, or certainly on the same side of the diaphragm, which is kind of like a dividing line that we tend to use that's borrowed from lymphoma for dividing lymph nodes. And as I said, they usually will not, even though they have more than one, they're not quite multicentric disease, but they don't meet those more inflamed diagnostic criteria that have the same degree of systemic presentation that multicentric patients have. And sometimes they're completely have no symptoms, just like a unicentric patient. And we think about them biologically as being very similar to unicentric disease, even though they are more than one. And I think this has been helpful and an important thing to appreciate, because we've seen certainly a number of patients who have been treated locally, they've been diagnosed, and the doctors say, I can count 2, and 2 is more than 1, so therefore you're multicentric Castleman disease. And by the way, I read about David's story, and that's going to happen to you soon, right? And that is not the case at all. Patients that have a disease that's very similar to unicentric disease, and that's the disease course that they present with. And so that's been important to get this out there. Where I think right now it's largely been described in the context of this unicentric patient, this unicentric paper that we published. I think we'd like to bring more attention to this clinical entity so that we help patients when they do have more than one area involved that are otherwise presenting like a unicentric patient, to provide that degree of reassurance so they don't get this sort of false counseling from a physician right in the beginning of their experience, which can be scary. So how do we treat unicentric Castleman disease? First line here is resection when possible. So surgical removal of the entire mass, all the enlarged lymph nodes in the area should be removed as if possible. And to some degree, we can also have to weigh the surgical risks against what the risks of our observation. So if you have all of your lymph nodes in an area that's pretty readily accessible to remove, then you can have a relatively easy surgery to get it out, like a day surgery, for example, or something that's not too different from a day surgery. The risks then, surgical risks are low. And so therefore we recommend removal because of the long-term risks, which I'll talk about later, of leaving the lymph nodes in. Different patients can have different areas of disease. And so some patients have it in a less surgically resectable position, perhaps maybe all the way in the back of the belly, like the retroperitoneum area, or the really deep in the abdomen. And then it's sort of an individualized decision about what the patient considers, after counseling, about what the long-term risks of leaving those lymph nodes are versus the upfront morbidity that they would feel from the surgery. And then there are patients who cannot be resected. And for those, we'd have to think about, again, where the lymph node is, what is in danger of pushing upon, what sort of structures are near, and whether there's a feasibility to having even a partial resection done in order to relieve any potential imminent damage to any adjacent structures that could be hurt by an enlarging lymph node. So about we have some data suggesting that over 90% of patients are cured with complete surgical excision. There are no formal guidelines for monitoring after surgery. We tend to recommend annual or sort of an individualized approach where it can be as much as annual imaging for 5 years after surgery, although that can also be balanced against some things like patients' age, radiation exposure, and how they presented, where the disease presented in as well. So it's okay for some patients who are not getting imaging quite every year, depending on how they're otherwise doing. And then, as we were saying before, some patients have symptoms that were their diagnosis and persist despite complete surgical excision. And this is what our recent American Journal of Hematology paper is focused on. And this is a clinical entity I think we're trying to bring more and more attention to overall. And I'll talk about those patients' experiences a little bit more in a little bit. And so that's why I put that little red thing saying, this is not the end of the journey for some patients. Not just it's not just a matter of getting the surgery and then they're done with Castleman disease forever. Although that is certainly the case for most patients, I would say. For patients who have big lymph nodes that are not surgically resectable, radiation can be considered. An embolization is an interventional radiology procedure where they cut off the blood supply for the lymph node. These lymph nodes tend to be very vascular. They're very dependent on the blood supply to grow. And there are ways of cutting that off to allow the lymph node to involute and shrink on its own. You can use, and then you can also consider debulking strategies. So maybe it's at a particular size where it's pushing against other vessels that make it too dangerous to cut out directly. But you can consider an approach where you get a systemic therapy that works head to toe, that allows you to shrink the lymph node just sufficiently that a surgeon can then later go in and cut it out. And that could be something as simple as steroids. It can also be this monoclonal antibody IV infusion called rituximab, which targets a protein on the surface of a white blood cell that is the most predominant cell population within the lymph node. So this causes your own body's immune system to clear those cells. So it can shrink lymph nodes by really destroying the major cell that's in the lymph node to allow the lymph node to shrink sufficiently that a surgeon can then later go in and cut it out. So for some patients who have big lymph nodes that look like they're in a bad spot and there's no way of safely cutting them out, this can be a strategy to taking an unresectable patient and make them resectable. For patients who have symptoms after surgery, there is no consensus management strategy, and we tend to take a very individualized approach. This is a paper, this is a figure from Sy and Mateo's American Journal of Hematology paper, kind of where maybe some people here online or in this room contributed to providing their own experiences in terms of which symptoms they felt after a complete lymph node excision, CLE. And so, general fatigue or tiredness, feelings of swollen and large lymph nodes and pain and drenching night sweats were among the most prevalent symptoms that patients experienced who had a complete excision of their lymph nodes. So they don't have any disease on the PET scan anymore, but still don't feel any better in terms of the overall symptoms that they were experiencing. The major thing that we have been doing with patients, particularly for ones who have inflammatory marker elevations, so they have elevations of their sedimentation rate, the C-reactive protein, or other inflammatory markers, is to trial therapies that work for IMCD patients, such as Siltuxan or Rituxan. I think the advantages of siltuximab is that it does go after IL-6, which is this known pro-inflammatory signal that is known to play a role in multicentric Castleman disease. So about a third to half of patients with multicentric Castleman disease will have their disease really impressively respond to this monoclonal antibody that blocks this pathway that's kind of IL-6. That's how white blood cells amp each other up and tell each other they're going to war. And so you can extrapolate for patients who have inflammatory markers, have the inflammation, but no longer have the Castleman lymph nodes, that they may also benefit from this siltuximab therapy. And certainly some do. I think the downside with siltuximab right now, particularly, is just, this is in general with the IMCD population as well, as we have no endpoints for therapy. It kind of is just an open-ended, indefinite therapy that we're recommending with concern to having relapses when you stop siltuximab. Alternatively, we have rituximab, which, as I said, is a monoclonal antibody that targets B cells, the major immune cell in the lymph node, and that you can think about having a very defined course of that treatment and seeing whether you have benefits. And there are other different sorts of immune modulators that can be individualized and we can discuss for individual patients, especially if they are refractory to these strategies. Again, it's very helpful, I think, for these patients when they have inflammatory marker elevations. I certainly see patients who don't have inflammatory marker elevations. They have symptoms despite complete lymph node excision, and it's just more challenging to know exactly what to do there, because most therapies that we think about for Castleman are some sort of immunosuppressive, immune modulating therapy. And without having markers of inflammation, it becomes hard to know whether this therapy is going to help someone or not. All treatments crossing the street all have side effects. Rituxan can be associated with some infusion reactions, and they're all immunosuppressive in some way, shape, or form. So they do increase risks of infection, and it's something we always think about now in the COVID era. Siltuximab, again, can alter some blood counts and liver function numbers and cause infusion reactions. And the others, I think, are just more immune modulating, with radiation therapy also potentially damaging tissues that are around where the lymph node was. Then there are the complications that you can have for leaving a lymph node in. As I said, some patients will tell me that, yes, I understand what these complications, but I want to leave these lymph nodes in because I don't want to have that big surgery that I would need to have a complete lymph node excision. And for them, these are the things that they have to weigh against. The concern of, are these lymph nodes big enough or near other structures that could cause damage with minimal amounts of growth? Unicentric Castleman lymph nodes typically grow very slowly. They hum. When they get caught largely accidentally, they've probably been there for years without the patient knowing. They grow very slowly. And so they would have to be really near something in order for us to think that there were any imminent risk of having damage to an adjacent structure. But it's certainly a long-term risk, especially if you're saying, I don't want to ever have a surgery and I'm 25 years old and I'm thinking about them living 60 more years of life, right? Then you can start thinking that eventually these lymph nodes might get to a point where they can cause trouble. If patients do have systemic symptoms, that's certainly a reason there's certainly a risk then to leaving them in, is that they would perhaps get worsening or not have improvement with their symptoms that they're feeling. Despite therapies, it won't likely be a therapy refractory, I would judge, if they didn't have the offending lymph nodes taken out. There's the risk of secondary autoimmune disorders. These tend to happen at diagnosis for patients. I'm trying to think if I've seen any case of a unicentric lymph node that was just like they diagnosed with, they left in, and then later, I can't think of any, or any that I've read in the literature, but please, if anyone knows them, let me know. But almost always these are a diagnosis. A patient with unicentric disease can have a secondary autoimmune phenomenon. The ones that are best well characterized are these paraneoplastic pemphigus and bronchiolitis obliterans. They're both quite morbid and can be both fatal. So this is one of the major complications of unicentric disease that can be that can be life-threatening to a patient. They tend to happen in children. So the vast majority of the cases I'm aware of have been pediatric, usually under 10, but there are certainly a few adults who've had this as well. And so this is the first one is a secondary autoimmune phenomenon where the immune system attacks the mucosal tissue. So they'll develop these awful lesions in their mouth and tongue that can make it very painful to swallow. Bronchiolitis obliterans is immune-mediated damage to the lungs that can also be, and they can sometimes go together. You can have both as a consequence of it. And so those can be fatal if you leave the unicentric disease unchecked. The first line therapy is to get the unicentric lymph node out, and that's a case where it needs to be done yesterday. These are usually patients who are admitted because they're having these worsening mouth lesions or worsening shortness of breath. If they're low on oxygen, they're in the hospital. And those patients get immediate surgical resection of the lymph node, and then often get additional modulating therapies that target these specific autoimmune diseases. And then certainly there's also a risk of transformation to non-Hodgkin lymphomas or other secondary malignancies like Kaposi sarcoma, like FDC sarcoma, if these lymph nodes are allowed to remain. It's usually like a low single-digit percentage risk, but certainly if you're thinking about decades of a younger patient with decades of life in front of them, that risk is then not as inconsiderable for an older patient who has a diagnosis of disease, because it will take a longer period of time to experience any of these sort of transformations, which are, I would say, a very low probability event, but certainly have been observed before. Now, I mentioned secondary autoimmune disorders, and I know from talking in the room that this is a real interest for a lot of people. And this is instances in which the unicentric disease very clearly caused its secondary autoimmune phenomenon, whereas you remove the Castleman lymph node, and the autoimmune phenomenon gets better. So a patient with paraneoplastic pemphigus or bronchiolitis obliterans, if you take out the Castleman lymph node, that can be enough for them to all of a sudden have a complete resolution. Certainly we observe another confluence of autoimmune disorders and Castleman that can be something a different beast than this exact phenomenon that we've otherwise described. And what I would say I see most frequently is a situation in which the Castleman histology lymph nodes were actually just a immunologic response to the autoimmune disease. So a patient, I was using this example earlier, where they were telling me that the major symptoms that they have were dry mouth and dry eyes. Dry mouth got so bad they actually went to the hospital because their tongue turned red. They had this like red tongue, it's called burning tongue syndrome, major complication. And they had a scan done, they found this lymph node, they had a biopsy, it was Castleman, and it's all unicentric Castleman. What they actually had was Sjogren's disease, which is an autoimmune reaction where you have autoimmune destruction to the salivary gland and the tear ducts. And the lymph node was really just a consequence of this sort of immune. So they can get Sjogren's treatment, and then the Castleman lymph node shrinks. It goes the other way around in that case. And this is part of the problem that we have right now, where the diagnosis is just not that specific, right? And this is an issue that you can also have for multicentric disease, whereas you can see they have a few different big lymph nodes, and you look at the lymph node in the microscope, and it's 100% Castleman. But guess what? They also have all the blood tests that you would think for lupus nephritis. They have all the very classic lupus symptoms where they have the wolf-like rash over their nose, the butterfly rash over their nose, the malar gnat rash and the kidney disease, and it looks like lupus kidney disease, and you give them lupus treatments and the lymph nodes get correct. And this is the problem that we have in Castleman in terms of our knowledge, that we don't have this very specific test that says this test, whether it's this test on the lymph node itself, like a special stain or something like that, or a blood test, that then this test can only be this way in Castleman disease. We just don't have that, and this is part of why we continue to have this frustration, is this lack of specificity with our diagnostic testing for Castleman. And so it requires not just having a really good lymph node, but also someone who's experienced with Castleman disease to kind of put this into the larger context and think about, does autoimmune actually make sense for the patient or not? And so this is why these diseases are somewhat intricately linked in complicated ways. Sometimes it's the Castleman causes the autoimmune, sometimes it's the autoimmune causing the Castleman. And sometimes, like you were telling me, so I honestly just don't know. And I wish I did. So I stole these next slides from the person who was giving this talk before me. I like them. Maybe I think a lot of this audience has been very in tune with Castleman disease in general, and maybe it's maybe they're a little bit beyond some of these principles, but I still like this as just kind of a gut check of what can we do after receiving Castleman diagnosis. I don't think anyone can see the top of this page because of this screen sharing thing. Locate an MD who is experienced with Castleman treatment. Learn about Castleman disease in your particular subtype. You're all here. Monitoring your symptoms and treatment, and which is always helpful. The symptoms that we are most interested in, although I think you can say any symptom is important if it's puzzling, persistent, and profound, 3 Ps. But the ones that we are most interested in would be night sweats, which we typically mean drenching night sweats. It's okay if you're feeling sweaty when you get to pee in 3 in the morning. I feel that way too. But if you're soaking through sheets or your clothes are all wet, that makes me more concerned that you're having like an active inflammatory process. Unexplained fevers, if you have a head cold, you can have a fever, but if you're getting fevers and you're otherwise fine, that makes me more suspect that we have an inflammatory condition going on. Poor appetite, just not hungry, feeling generally unwell, losing weight without meaning to. Again, some people will say, oh, that's so obvious if I'm losing 20 pounds. But I swear over and over again, people can be quietly happy that they've lost weight. And it's only when I specifically ask that they will finally go, oh yeah, I've lost 20 pounds. And I don't know why I didn't change. It's one, and if you change your diet, if you're more active than you used to, certainly, and it's explainable, that's certainly okay and encouraged. But if you lost weight and you don't know how, that's a red flag that we have an uncontrolled inflammatory process. Pain, skin lesions, we typically see with more multicentric disease, but certainly something we want to always pay attention to with any sort of inflammatory disease. And anything that's puzzling, persistent, or profound. It's bothering you, it's not going away, I don't know exactly what it is, and I can't otherwise explain it. Let your doctor know. Don't mind feeling these things. And all we can do is do our best to try to unify it, either using our general internal medicine hats. Unicentric Castleman patients are just as able, just as likely as everyone else in the world to get all the other things that other people that people get, but also thinking it through the context and prism of unicentric Castleman disease. Can we relate this to a disease process that we need to, as a subspecialist or a specialist, treat? Keeping track of your lab values. Those lab values mostly mean your blood counts, your inflammatory markers, C-reactive protein, sedimentation rate being 2 of the most important, I would say. Kidney function as well, measured by the creatinine. thinking about mind, body, and doing things of staying active and thinking about good appetite. This is so important, and I feel like I need to be listening to my own advice a lot of this. Between work and the kids, I don't really exercise as much as I should, but it is infinitely more important when you have any health condition of any kind. This becomes more acutely relevant. Staying active, walking at a brisk pace for a few miles a day, a couple miles a day, paying attention to a diet. I would say diet questions are the things I get the most. Both from a Castleman perspective, like the sort of immune health perspective, and then also from the oncology perspective when I'm taking care of cancer patients, is what should I eat, doctor? Is there a particular good cancer diet or inflammation diet? Unfortunately, there's a lot that says there is, but there really isn't any one particular diet that we know is being particularly, or one kind of food you should or shouldn't eat that is directly linked toward your disease activity. What I would say is that having a diet that is balanced, a Mediterranean diet that focuses on grains and olive oil, and limit carbs in moderation, is always a good strategy for maintaining good health. It helps with both heart health, and there is some evidence of using it in the context of inflammatory disorders as well. So staying active, having a good diet, avoiding processed foods, in particular, are always, which I think we have some yummy ones out there, but avoiding them generally are really smart ideas for any patient who has any sort of health issue, and it will just make you feel better. And if you're already having trouble, this can provide some degree of benefit, and you don't have to take a pill to achieve it or talk about side effects and things like that. And then seeking support. I think sometimes talking about anxiety and stress can be tricky with the Castleman disease group because there's so much frustration that comes from having a rare disease. And this concept of,
Hi, Dr. P, I'm sorry.
no worries, of having a rare disease and having this trouble of like feeling like you need to prove yourself to your doctor or something like that, right? Like, no, doctor, I am feeling these symptoms. And them, maybe feeling like you're not being taken seriously or not having your issue actually dealt with the way you want. So talking about stress and anxiety can be tricky because then it seems like you're getting dismissed. Oh, this is just nerves or something like that, right? And it's not. Your symptom is your symptom, and that's not just because of nerves, and it could even be related to your Castleman disease. But still, making sure that we take steps to have support, loved ones in our life that we can talk to about it, having therapy, because you know what? It's not just the chicken or the egg. I'm sorry, it is a chicken the egg situation, which like, it's not I'm feeling stress and therefore I feel the symptom. It's I'm feeling the symptom and it's causing me stress. And guess what's also causing me stress is the doctor not taking these things seriously. And having then a treatment for that stress, even if it's being caused by the symptom, is still helpful to just treat the stress, especially if you're not getting a good answer about what to do with the symptom. Having something that helps you provide some degree of coping, whether that is loved ones that you can talk to, activities that you know bring you joy, or seeking more professional therapy and medications for anxiety can just be helpful in and of itself, even if the stress is caused by both the symptom and your doctor's response to the symptom, it can still be helpful. And so that's why I think I wanted to leave this here, even though I think a lot of this is basic information to this crew that I think is ready, that knows these things and has lived these things, because I think there's still just good things to always reiterate for diseases, especially patients with rare disease. All right, so that was a lot of what I was talking about, the clinical aspect. I told you, I generally have a research hat here where I spend a lot of time pipetting and thinking about the science of the disease and trying to answer big questions, things that we tend to punt in clinic because you know what, there's just not a good answers. Why don't we know what causes this thing, right? And here's the thread of this story that I've been going at. Some of it is related to how I stumbled into this world scientifically. I told you about more personal experiences taking care of patients, but there was also a science way that I got involved here. And that's looking at a kind of rare cell of that's part of the makeup of the lymph node. That isn't just a structure, that was always thought to be a structural cell, just the, it divides this room, says that's that part of the lymph node, and that's that part of the lymph node. But actually isn't just a static wall cell. We know now it provides signals to the white blood cells and tells it what to do. They're talking walls. And this has been my suspicion that these cells may play a role in actually causing this disease. One of the frustrating things, we know that these white blood cells, these that are members of the military of the immune system that live in the bases of the immune system, the lymph nodes. These lymphocytes are the kind of white blood cells that live in the lymph that are military white blood cells that live in the base, are playing a role in causing this disease. That's what we're seeing under the microscope. These cells look like they are going to war. Why are they going to war? I don't know. Obviously we have HHV8 associated HHV8 associated MCD, but beyond that, there's no known virus or infectious trigger, despite a lot of people using both standard approaches and then all these fancy research approaches to find is there some little virus that no one's ever heard of before that could be causing things. We haven't been able to find that. We think about autoimmune disease, but it's not. But Castleman is different from autoimmune in the sense that it's not necessarily attacking any one specific organ. The immune system is just going to war. It's not just attacking the gut like ulcerative colitis or Crohn's disease, or attacking the central nervous system like multiple sclerosis, or attacking the joints like rheumatoid arthritis. The whole body seems to be going to war, or just this one lymph node in the context of unicentric disease looks like it's going to war for unclear reason. And when we look at those white blood cells, both under the microscope and then using fancy research techniques, besides the fact that they look inflamed, they don't look that distinctively different. And that's been one of the frustrations about what's going on with this disease and why haven't we figured this out already. We know they're activated and when they shouldn't be activated. We don't know exactly what way that they're activated that looks any different than how they should activate, other than they're just doing it inappropriately and we don't know why. So in the lymphoma world, well, this is a little bit easier because guess what? In lymphoma, you have one kind of these cells, one of these cells that just went crazy and made tons of copies of itself. So you look under the microscope, you do special stains or special techniques, and you see one cell that's divided multiple times, like the broomsticks in Fantasia. And so you can say, yeah, that's what was going wrong there. With autoimmune disorders, you can oftentimes find an antibody that's in the blood that we know reacts with part of the body and say, yep, that should be there. We haven't been able to find that for cancer. We can't find that antibody in the blood. We can't find that particular weird white blood cell that's only weird in Castleman disease. We haven't found anything specific when we look at the white blood cells. So what I've been suggesting is that it's actually some of these cells that are in part of the lymph node that play an immune regulatory role that could be going weird. And I think this in part because they look weird under the microscope, for one. The follicular dendritic cell prominence that was described at the science section, or the hypervascularization of the blood vessels, these are all these stromal cells, these non-white blood cells that are part of the makeup of the lymph node that look weird under the microscope. And then in the context of unicentric Castleman disease, we haven't seen this yet in multicentric disease, but in unicentric Castleman disease, there's been some evidence suggesting that these cells not only that play this sort of immune regulatory role, like they're the air traffic controllers was the analogy of the immune system. There's some evidence that in unicentric disease that they are copies of each other, that there was one of these stromal cells, one of these non-white blood cells that make up the walls of the lymph node that actually are growing. There's one of them that's growing kind of like the same way you might have a polyp in the colon, that these are growing a little expansion of the one kind of cell. And my suspicion is that when it happens in the colon, well, guess what? That cell just grows until ideally you had a colonoscopy and the gastrointestinal doctor removed it, right? But in context of, but it doesn't do anything other than grow. But these cells are special cells. They're cells that can regulate, that control the immune cell. So they don't just grow. They bring in all these white blood cells inappropriately. And so that's what I've been trying to do, is identify what these cells are, these stromal cells that are growing inappropriately, and showing that they actually are copies of each other. And so what I've been using some advanced techniques, and if anyone here has donated a lymph node, this is part of what for unicentric, this is part of what we've been trying to do, is use fancy techniques that allow us to define all these very specific populations of different kinds of these white blood, of these sort of lymph node wall cells, these stromal cells that play different precise roles in the regulation of the immune system. We can identify them, and then what we're trying to do is show actually that they're actually even that they're clones of each other using fancy genetic approaches. And so that's some of the things that we're trying to do. What was pretty cool is that a Chinese group originally published that in unicentric Castleman disease, there's a mutation in this gene called PGFR beta. About 70% of the 41 cases that they tested. And this has now been confirmed by, well, I can tell you, I personally confirmed this result. And I've seen that's unpublished, but other people have published from 2 different groups, including somewhere in the West Coast, Stanford, I believe, have also found that this mutation is present in unicentric Castleman disease. And what this Chinese group did is they actually asked which cells had this mutation, and it's not the white blood cells. It's the other cells, the stromal cells that appear to carry this mutation. And what's really nice is that this is a drug. This is a gene that we know a lot about, and that we have already available drugs that are FDA approved, that are used for a whole bunch of other different indications. So we know what their side effect profiles are very well, that target this. And so this might provide a new line of therapy that we can offer patients, particularly ones with unresectable disease, to help and get regressions of their other unicentric Castleman disease. I can do this in the lab, so I can use this mutation. I can make cells have this mutation in PGFR beta, and I can get them to grow, whereas otherwise they wouldn't grow. And I can treat those cells that do grow inappropriately with these drugs that are already available and get them to stop growing. But this is just cells in a dish. We're going to try to also do this in mice as well to really show that this matters in living things, in living organisms. So those are some of the next steps that we're doing. I'm trying to get answers to these big questions that I said, when we see patients in clinic, we just have to accept as the realities of the world we are in, but we're hopefully trying to make some progress on that as well. And so that's what we're working toward: faster, simpler, clearer diagnosis. So pathologists, where you got, where that first looked at your lymph node gives you the same answer as the pathologist at the fancy place that maybe looked at your lymph node later on. And that we have options for patients who have bulky or unresectable disease, and maybe we can apply some of these for patients who have symptoms after complete resection, or multicentric patients as well. And so that's a little bit of where we're at. And if anyone has an upcoming surgery to remove a Castleman lymph node, please let us know. We're very interested in contributing, and this is the kind of science that we want to do to try to inform these big questions and help the next patients who get diagnosed. Because no one's happy with where things are right now. We're applauding the progress we've made, but we have a lot of work to do. Okay, and that's it. I'm happy to answer any questions.
So Josh is willing, we are more than happy to take questions now. We did run a little bit over time, so there is lunch that is being set out, and Josh will be on the physician panel starting at 1,
Yes.
I believe. So he will be able to take questions there as well. But
Yes, so if you want lunch, I'm not offended, go get lunch, it's fine.
it is,
But if you have any questions, I'm also happy to.
currently time.
Hey, it's good to see you.
Good to see you too. And I have a question.
Yes,
You and Dr. Nasta started me on obinutuzumab.
yes,
Working great.
awesome.
When are we going to start a trial so other patients might be able to benefit?
I love that idea. I love what you're thinking of that. So like, yeah, obinutuzumab, right? Like modern day version of rituximab.
Oh, and the rituximab was effective.
Yes.
At least it did with me.
It can, yeah. And that's also known for other diseases as well.
Then bring it back up, I'm telling you. I had a few symptoms, but nothing like I did. I feel better than I have in years.
So happy to hear that.
So am I.
Right, because there's not a standardized approach. We have a lot of tools now, right? And with lymphoma, we have different strategies that we can apply, right? Non-chemotherapy, not chemo, but things that we can crib from them that give us different ways that we can modulate the immune system, target B cells differently, right? Obinutuzumab is a new version of rituximab, but it also has a little bit of difference in how it works. And hopefully get benefits for people, right?
Whatever that difference is.
But you're right in that we need a standardized approach, right? It can't be just the individualized.
Let's try that. And as far as I know, as far as anyone I've talked to, I'm the only one on it.
Yeah. That may
So let's do this.
that may be, I love it. I'm game.
I'm game too. Let's go. Just let me know what I need to do.
I will do.
And you know I will.
The thing that we most need would be other, I think, we need to work on the regulatory aspect, right, of course, and get the company involved, because that's a patent drug and everything like that, they need to buy in. But you know what we would do, I think, first, convince them, get them interested, and show them patients who need it, who would like, they would fit, they would be on a trial.
And they are sponsoring me.
Yeah.
The company is sponsoring me.
That's
So
a-
I would think that that would be a good chance that they might be willing to, go ahead with something.
That's so cool.
Either pay for it all, the whole cadoodle.
So, yeah. I
They're a
think
great company to work.
if there are other patients in this room who are having symptoms or on the internet who are having symptoms, despite having a complete resection of their unicentric lymph node disease, reach out to Penny
Reach out to me.
and we'll start organizing people together.
Okay.
Because then once we do that, then we can turn around and say to the company, hey, look, we already have 15 people
Ready to go.
ready to go.
Yeah. Let's do it.
I like it.
See what we can do. Maybe we can help some more people.
Yes. I love that idea. Thank you for sharing that. I haven't seen you in a while, so it was nice to hear the update.
Wait.
Does anyone else have any questions?
Yeah, how do you treat the fatigue side effect when you see the infections?
Poorly, right? It's one of the hardest things to do is treating. So if someone asked about treating fatigue, and I would say it's one of the hardest things to do, right? I do think sometimes having like you can think about IMCD like therapies, particularly if you also have the increase in the inflammatory markers in the blood, and you can say, look, we're going to try this. I know what the side effects are, but my fatigue is just really bad, and I want to. It makes it worthwhile for me to try. And I'd be game to trying, right? Oh, an IMCD like therapy and seeing whether you have the benefit from it, right? And I try to weigh some of those, what those could be. It could be obinutuzumab, right? They could be rituximab. And the nice thing about those also is that you could think about more defined treatment regimens for those, or you can think about something like sulfoxamine and seeing if you have a benefit with this. What? Yes. Gotcha. Because we've had some international patients come to University of Penn, and I would agree that this is sometimes an issue. There's so much I'm jealous of about the European and I presume Australian health systems in terms of their accessibility. But one of the, I think the difficulties can be for rare disease patients when yes, you're going to suggest a non-standard approach because there's just not enough patients for us to have these large scale, high quality data that they have for a disease like lymphoma or something like that. That's more common. So I'm not quite sure about what the rules are in Australia, but maybe your physician can navigate something like that. I'd be happy to like talk to them, just, if they want to reach out, and I can provide some counseling if that's helpful to them about what experiences we've had with patients. But that would be also then what they can do, right? So I don't know if it's a physician willingness or what they can do in Australia.
Dr. Brandstatler.
Yes.
My name is Robin. I'm from Atlanta. Question for you. So I got diagnosed with unicentric Castleman disease last year. And after I got my flu shot, I'm a nurse in a hospital in Atlanta. So of course I have to get my flu shot. 12 hours after I got my flu shot, I had 3 lymph nodes pop up in my neck out of the blue. So now I'm like, I'm not getting a flu shot. I'm not getting another COVID vaccine. I'm scared to get any vaccinations because I think my body is going to hyperreact to everything and start causing these lymph nodes to pop up in my arm again or up under my arms. So what do you suggest?
Yeah. So you had local lymph nodes, and you said in the neck, was it also in the armpit as well, in the axilla?
Well, originally I'm a labor and delivery nurse. So I originally had a sore spot in my arm. I totally found this by accident because I also do first assisting in the OR. And so when I was doing the retracting, I just thought, well, I was retracting too hard and my arm was sore. Didn't even think anything else about it. This went on for months. So, and then it started getting warm to the touch. It started swelling, and I'm like, something's not right. One of the docs that I work with suggests that I go see an ortho doctor. Sent me to one. They did an MRI. He said, there's definitely something in there. We don't know what it is. He said, let's take it out. I'm like, okay. Took it out. They sent it to LabCorp. LabCorp didn't know what it was. So LabCorp sent it to Johns Hopkins. Johns Hopkins said it was Castleman's like disease. And then it's been kind of just a whirlwind there. I am seeing Dr. Mary Jo Lechowicz down at Emory.
Oh, wonderful.
So I've been seeing her. She's fabulous. But I have to go see her in October. I'm gonna have a round of blood work done again. So I'm interested in, would you like samples of that blood?
Yes, probably is the answer. Please reach out to Bridget.
Okay.
We always are interested in samples.
Because I feel like I'm having a little bit of a flare up.
Okay, please.
So I'm like, let's see if we can get that blood. But like I said, I'm afraid to get the immunization because I'm afraid that lymph nodes are going to start popping up all over the place again.
Yeah, I hear exactly what you're saying. We certainly notice for IMCD patients that their lymph nodes can get bigger after the vaccine. they usually, so what we do is we say, don't get a scan right after vaccines, because then they're going to think your disease is progressing.
Correct.
For MCD patients, they tend to then regress after, like, so yes, they have like this sort of tendency to have a bigger response with the lymph nodes, but then they tend to regress back to wherever they were before after a few weeks of being vaccinated. I have seen patients who had their initial diagnosis of UCD or IMCD after either a COVID infection or a COVID vaccination. And I have someone in the room here who's written an awesome paper on that experience as well, in the context of Castleman and COVID. Generally, what we've seen is that it's been safe for people to get the vaccine, despite the fact that they may have lymph nodes that might get bigger. They tend to regress afterward for it. I would work with Mary Jo about some of the particulars of your case.
Okay.
To think about whether it might make sense to at least try it once more, or whether it's better to hold off for now.
Okay.
But generally, I would say for most of the people, even the patients who have had like what it sounds like for you is like they got the vaccine and then they got a new diagnosis, they've generally been okay getting vaccines later. And what I suspect is that they were just like set up for it, and that this was like whatever, they were just waiting for some sort of inflammatory trigger to happen to them, which is why it could be the COVID disease itself, it could be other diseases, and that there was just, a vaccine is nothing more than an inflammatory stimulus, right? It's one we're intentionally doing for the purposes of triggering a desired immune response.
Correct.
I expect that that's what happens, is that if it wasn't this, it was going to be whatever else that would have done this to you. That's some weird Monday morning quarterbacking that I can't really do for sure. But that's generally what I've seen, is that there can be a variety of inflammatory stimuli that can, whether it's vaccine or infection, that can precede patients getting UCD or IMCD new diagnoses. So I think it should be safe to get a vaccine, but I would work with Mary Jo, because she's certainly really smart and she's taking care of you down there.
Okay. Thank you.
All right, so I think we're gonna break for lunch, but we'll see if we get the physician panel at 1. So thank you very much, Dr. Grinstetter.
I'm happy to hang around here if anyone has any comments. Thank you, everyone online. Yes, I did.